Καλησπέρα σας. Για μια ακόμη φορά σας καλωσορίζουμε όσες και όσους για μια ακόμη φορά ενώνονται στην σειρά των μαθημάτων Υγεία και Θρησκεία, που έχουμε την ευκαιρία να ακούσουμε πολύ σημαντικούς ομιλητές από την Ελλάδα και το εξωτερικό πάνω σε αυτά τα θέματα. Σήμερα έχουμε μια μεγάλη ευκαιρία και χαρά και τιμή να έχουμε μία από τις πιο σημαντικές προσωπικότητες στα θέματα αυτά. Είναι η καθηγήτρια της ογκολογίας, Professor Tracy Balboni, η οποία είναι η ηγέτης, θα λέγαμε, στο Πανεπιστήμιο του Harvard πάνω στην προσπάθεια που γίνεται για να συνδεθούν πλέον η πνευματικότης, η υγεία και η θρησκεία. We are very privileged to have today as our keynote speaker, Professor Tracy Balboni, who, as I said in Greek, is behind all the effort that is being made the last years, at least at Harvard University internationally, on the issues relating health and religion and spirituality. Professor Balboni is a graduate of Stanford University, Harvard Medical School, Harvard School of Public Health, and she's currently the director of radiation oncology at Harvard Medical School at Dana-Farber Cancer Institute. She's the clinical director of supportive and palliative radiation and oncology service at the Dana-Farber Center for Cancer. And she's, as I said, the co-director on several projects and publications on health and religion. Her primary research interests are indeed in palliative care, including the psychosocial aspects of advanced cancer and radiotherapy for palliation. Within the psychosocial aspects of advanced cancer, she has a particular focus on the role of religion and spirituality in the experience of cancer. We have been very lucky and privileged and honored to have Professor Balboni in our last year's series. And this year we are anxious to listen to a very important topic entitled Historical and Empirical Reflections on Spirituality in Serious Illness. Before I offer the podium to Professor Balboni, I have to make a kind of sad announcement, but it is related to both theology and partially health. Just a few minutes ago, one of the leaders of theology, Professor and academician John Zizioulas, the Bishop of Pergamo, passed away. As you probably know, has published extensively. He was a professor of theology in several universities, had his training at Harvard, along with some of the, he was 92 years old. So he was, along with the most renowned Russian and other international theologians of the diaspora, expressing very important ideas and being respected worldwide. So because of that, I will have to attend kind of the immediate religious services. And I asked Professor Balboni to continue, and we are not going to have a time for questions, although I think that her talk will be, as always, so informative that additional questions might not be necessary. If you do, you can find the answers in her textbooks, and you can Google and order through Amazon her new book, which is really very, very important for all of us who are interested in these issues of health and religion. Professor Balboni, thank you again for the honor of having you and spending your time with our Greek audience in Greece and in the States. Thank you again, and please go ahead.
Wonderful. Thank you so much, Professor Linos, for that very warm and kind introduction. I'm sorry to hear about this loss, and but it really is a privilege and honor for me today to be with all of you. I'm coming to you from chilly Boston. I imagine it's much warmer where you all are. And as Professor Linos has said, I'm going to share with you historical and empirical reflections on spirituality and serious illness. This photograph here is actually taken by my father in the Grand Tetons in the United States, sort of in the northwestern part of the United States. And it's just an illustration of how, we can consider a scene both historically. We could talk about the historical geology that rendered these absolutely spectacular mountains, which the Grand Tetons certainly are. It's a beautiful scene. Or we can consider also ways in which the nearby surroundings reflect upon those mountains, like the water in the forefront here, reflecting the beauty of the trees and of the mountains themselves. And so that's what we're going to do today. We're going to be considering both the history behind the relationship between spirituality and medicine. And I think it's very important that we consider that history, because it has such implications for where we are today, including the experience of patients, the experience of those of us who provide clinical care to patients, and then finally for healthcare institutions. And then I'm going to turn to an empirical lens and reflect on the evidence regarding the role of spirituality in serious illness and health. So first, it's important that that I share with you kind of the definitions that I'm using, which will be arising throughout this talk today. So first, the definition for spirituality. This is the International Consensus Conference definition for spirituality, where it's defined very broadly, appropriately broadly, as the dynamic and intrinsic aspect of humanity through which persons seek ultimate meaning, purpose, and transcendence, and experience relationship to self, family, others, and the significant or sacred. It's expressed through beliefs, values, traditions, and practices. You can see a very broad definition of spirituality to capture the myriad forms in which it can be experienced. Religion is a related term. It's typically a set of spiritual beliefs that are shared by a community of persons, often associated with common writings and practices. Another key term is spiritual needs, sometimes also termed spiritual concerns or spiritual distress, spiritual struggle, spiritual pain, existential distress. And these are essentially needs related to a person's spirituality, whether spiritual questions, concerns, the needs for practices, or actual real struggles. And then finally, spiritual care. Spiritual care is the recognition of and attention to spirituality, in particular to the practice of medicine and public health within healthcare. And it generally relies on a multidisciplinary team of individuals. So with that, I'm going to turn to the first part of my talk, which is this historical relationship of spirituality and medicine and how that historical relationship has implications for healthcare. So I'm going to begin in classical antiquity, in Greek and Roman times, when we had, of course, the worship of a pantheon of gods. And as in this John William Waterhouse painting, we see a mother bringing her sick child, her sick son, to a temple of Asclepius in order to obtain healing. And of course, it's in classical antiquity when the gods were worshipped. And in the case of healing, the Greek god Asclepius was worshipped. And of course, it's in these places that not only sacred rituals were performed, as in this painting, we see the priest performing a sacred ritual, but also individuals underwent various bodily forms of healing as well. They typically spent time within the temple, and various bodily forms of healing were performed as well. So there's very much an integrated practice of the spirituality of that time with the healing practices of that time. Of course, this is during the time of the rise of Hippocratic medicine, which is a much more material form of the practice of medicine, where health is due to the balance of the four humors: blood, phlegm, yellow bile, and black bile. And of course, illness is the result of the imbalance of those. So very much a material emphasis on the origins of health and of disease. And yet, even Hippocratic medicine was founded on the spirituality of that time. And we see that in the Hippocratic Oath, where it's sworn by Apollo, the father of Asclepius, Hygeia, and Panacea, his daughters. So we can see this kind of grounding of even a very bodily form of the practice of medicine within the spirituality of that time. And that continues throughout the culture even to today. And we see vestiges of this relationship even in our symbolism. So for example, as you all know, the rod of Asclepius is very frequently, it's a ubiquitous symbol within the practice of medicine due to these origins. And I'm just providing you one example here, that of the insignia of the World Health Organization. But moving forward in time into more recent history, so for example, into the Enlightenment and into the postmodernism period, the 1700s to roughly the present, we see not only a separation of the emphasis on the spiritual and on the material, and hence medicine having sort of a concurrent embrace of both, to now a zeroing in on the material. So it's during this time that we see the growth of materialism, which is the idea that truths about humanity are understood through the study of the material world. And of course, of reductionism, which is sort of the primary tool of materialism, which is where if we break down those materials into their component parts, we can truly understand truths most thoroughly. And of course, these philosophies bring about wonderful abilities on the part of humanity. The ability to understand our material world, including our bodies, including disease, and the ability to intervene in order to cure disease and to alleviate suffering. Of course, because of this great power, the empirical method becomes a primary way of understanding truths for humanity. And with this, medicine really grows in its material focus and care and loses its spiritual emphasis. But there's immediately a recognition that there's a problem. And it's beautifully illustrated in this painting by this artist, William Blake. This painting is entitled Newton. And as you can tell from the title of the painting, this is the figure of Newton. Newton is here portrayed as a young, muscular figure whose gaze is fixed on the geometric forms on the scroll below. And there's this wonderful light that's cast between the fixed gaze of Newton to the material forms below, all symbolizing the wonder and the beauty and the light that comes from the study of the material world. And yet there's also a commentary here. And we see it in what surrounds the figure of Newton and what actually the figure of Newton is seated upon. And it's upon these myriad forms, difficult to pin down exactly what they are, that surround the figure of Newton and upon which he is situated, just illustrating how there is so much of who we are as human beings that is outside that fixed gaze on the material. So these are, of course, philosophies, but I would argue that these philosophies are like the water around the fish. They influence how we interact in culture, and certainly how we care for patients in healthcare settings. So I'm going to share with you a story of a patient of mine. This is not her photograph. This is just a photograph from the internet, and yet it reminds me of my patient. This is a 58-year-old woman who I had met at the time of her initial diagnosis of cancer during her definitive treatment. But then ultimately, unfortunately, she developed metastatic disease years later at the age of 58. And in this setting, she had multiple admissions to the hospital, and I saw her for consideration of possible palliative radiation therapy. And it was during one of these visits that she said to me, she was describing to me how much she hated being in the hospital. And then she further explained to me the reason why she felt so uncomfortable in the hospital setting. And she described, I can almost hear this place telling me that all I am is a body full of tumors that are killing me. I can almost hear this place telling me that all I am is a body full of tumors that are killing me. She was describing to me that fixed gaze. She felt the fixed gaze of medicine, as in that painting of Newton, on her body. And yet it wasn't seeing the rest of her. And of course, her body is dying. So that emphasis on her body only reminds her of the fact that her body is disintegrating. It's being lost. And yet there is so much of her that is outside her physical body that she feels is neglected by this emphasis, by this ignoring of the rest of who she is as a human person. But it goes beyond patients. I would argue it also influences caregivers themselves. This is Dr. Paul Kalanithi, a neurosurgeon and author who wrote this book entitled When Breath Becomes Air. And this is a book about first his training, his going into medicine, his training as a neurosurgeon at Stanford. And then in the middle of the book, it pivots on his diagnosis with an advanced lung cancer. And ultimately, he writes about his experience with metastatic lung cancer. And then it's actually his wife who ultimately ends up writing the final words of the book as he's passed away by the end of the book. It's really a powerful book in which he describes to us, particularly in his describing his entrance into medicine and his training within medicine, his desire to care deeply for patients, his desire to connect with them and with their families. And yet his training completely sort of divorces him from that desire. He describes it in this way within the book. He writes, some days, this is how it felt when I was in the hospital. Trapped in an endless jungle summer, wet with sweat, the rain of tears of the families of the dying pouring down. I was losing sight of the singular importance of human relationships, not between patients and their families, but between doctor and patient. You can hear him describing even him being stuck within this fixed gaze. He's unable to look beyond, and it not only causes him to neglect the larger picture of his patients, but you also feel it neglecting that within himself, the humanity that has caused him to desire to enter into the vocation of being a physician. And I would argue to you that there are patients like my patient and physicians and other clinicians like Dr. Paul Kalanithi, who are in hospitals, in healthcare settings all the time together, experiencing this and feeling this sort of divorce from the humanistic aspects of what it means to be a human being because of that fixed gaze. And I would argue that it goes beyond that. It actually affects healthcare institutions, certainly within the United States, that has been the case. This is a commentary from some time ago, from the mid-1990s, but sort of with leaders within the palliative care movement commenting on the fact that death has become so technicalized, and then commenting on sort of some of the origins or reasons why this has developed. And I'll just read you an excerpt from this paper in the New England Journal of Medicine. They write, the experience with this patient, they're describing an experience of a patient, is a disturbing illustration of the care received by many terminally ill patients in U.S. hospitals. Despite repeated requests that he receive no further life-prolonging treatment and that he be allowed to return home to die, the patient underwent a lung biopsy, 3 CT studies, daily phlebotomies, an insertion of multiple nasogastric tubes, as well as a gastrostomy tube, and he spent the last month of his life in the hospital. So you have to pause and you see this dehumanizing care illustrated by this story. And you have to ask yourself, who are the physicians, the nurses, the other clinicians involved in this individual's care? Did they really intend for this form of care to transpire? And I believe, we don't know who these people were, but I believe they're very well-intentioned people. So you have to ask yourself, what causes these well-intentioned people really desiring to do what is good, to provide care such as this? And I would argue to you, it's that fixed gaze. It's the fact that those clinicians, that healthcare setting, the culture of it is centered on focusing on the material body. And as a result, all of the assessments, all of the tools that are used to intervene are focused on the material body. And hence those individuals have trouble seeing the larger picture of care, have trouble seeing the larger picture of the patient in front of them. And unfortunately, it can result in care such as this. So what I'm arguing to you, as we sort of reflect historically, is that in the past, spirituality and medicine were quite integrated. And with that, care had a much more balanced focus on bodily and spiritual health. Of course, it was during that time that we had very few tools to address bodily health. Of course, that needed to change. But as we began to focus in on the physical, we lost. And there began to be a schism with the spiritual. And as a result of that, care has become too hyper-focused on the body and upon technology. And that has resulted in, of course, many wonderful abilities to intervene, but also issues because of the lack of the attention on the whole person within care. So with that, we'll turn to the evidence. We'll reflect in an empirical way on the role of spirituality within serious illness. I'm going to focus my attention there, but I'll also touch on its role within health more generally. So I'm going to be sharing with you this JAMA Special Communication Report. This was published last year in the Journal of the American Medical Association, a large systematic review, which was done because of the fact that there's been growing research on the role of spirituality in illness and in health. But however, there's been fairly proportionally little uptake into healthcare. And in part, that's because the research often doesn't get into high impact journals. And additionally, although this is improving, there's been quite a bit of bias against the recognition of spirituality and health. Hopefully, there is, however, an increasing recognition of other components of health as being important, including the spiritual. That's initially sort of suggested in the 1948 WHO definition of health as not merely the absence of disease or infirmity. So if for the first time sort of other components of health are named, the spiritual isn't named, but it's certainly implied. And by 2002, we actually see it named within the WHO definition of palliative care as a key component of palliative care. So this project's goal was to provide a comprehensive assessment of the literature in spirituality and health, both for ill and healthy populations, and to name those implications for the practice of medicine by experts, the requisite experts in the various fields. This project was a many-year-long project. It began with systematic reviews of the evidence over the past over 20 years, both in spirituality and serious illness and spirituality and public health. It then involved the gathering of a Delphi panel who then reviewed the synthesized results of those systematic reviews and provided evidence statements, essentially naming what that evidence is telling us and then providing us with suggested implications for how that evidence should impact the practice of health and serious illness and in public health. We then analyzed those qualitative evidence statements and implications using qualitative analysis, and then created a portfolio of evidence statements and implications for healthcare. The Delphi panel was then reconvened and quantitatively assessed the evidence statements and the implications for healthcare. And then finally, that data was synthesized, and I'll be showing that to you in a moment. I will say a little bit more about the systematic review of the literature. It involved multiple databases as listed here. There was a 2-person screening, and then a 2-person extraction. And then finally, the data were summarized and within various categories, 5 within serious illness and 5 within public health. To be included, these had to be the most robust studies. So within serious illness, they had to be prospective, cross-sectional descriptive studies, meta-analyses, or randomized trials. They had to have 100 or more patients, and they had to use validated measures of spirituality. Within health outcomes, similarly, they had to be prospective, case control studies, meta-analyses, or randomized trials. They had to have 1,000 or more patients for cohort or case control studies, 100 or more for randomized trials, and they had to use validated measures of spirituality. So these were the best of, sort of the cream of the crop of the studies addressing spirituality and serious illness and spirituality and health outcomes. This is the systematic review of spirituality and serious illness. You can see we began with nearly 16,000 papers that were reviewed. And ultimately, over a 23-year period, that resulted in 441 papers in spirituality and serious illness that met those rigorous criteria that I mentioned to you a moment ago. Spirituality and health outcome involved the review of just over 12,000 papers, ultimately resulting after that sort of screening process and choosing only the best papers, a total of 276 papers over a 23 period in spirituality and health outcomes. So now let's turn to the results. This is a table from the paper. This is the sort of a summary of the literature on spirituality and serious illness. These are the 5 categories of the evidence. And even within, remember, I just told you that we only took the cream of the crop, the best of the studies, but even within that, we only examined those with a low to moderate risk of bias. So even sort of further selective as far as what was ultimately used in the data synthesis. These studies involved many continents across the world. They had robust sample sizes, and they used a variety of validated measures. Ultimately, our Delphi panelists took the evidence that was qualitatively derived and then deemed whether it was supported by strong, moderate, or inconclusive evidence. And these are the evidence statements that actually met the criteria of being supported by strong evidence. So first, religion or spirituality are important to most patients with serious illness. Spiritual needs are common. Spiritual care within medical care is frequently desired by patients. Spiritual needs are frequently unaddressed. Religion, spirituality can play a role in medical decision-making. Spiritual care is infrequent in medical care. Provision of spiritual care to patients with serious illness is associated with better end-of-life outcomes, and unaddressed spiritual needs are associated with poor patient quality of life outcomes. And I'm just going to provide you, so those are the summary, that's the summary of the evidence provided by our expert Delphi panel, but I'm going to provide you with a few examples of this evidence. So first, regarding the importance of spirituality and serious illness, this is a national study of cancer survivors, over 8,400 of them, in which they were simply asked, my faith or spirituality has helped me through my cancer experience. And you can see that the majority, about 70% of patients, indicated that it was quite a bit or very much an entity that helped them through their cancer experience. This is a study done actually at 4 Boston area academic centers, 75 randomly selected patients receiving palliative radiotherapy. So these are patients with advanced cancers. 78% of them indicated that religion or spirituality was important to their advanced cancer experience. And then those patients that indicated that it was important were asked, well, how? How has religion or spirituality been important to your cancer experience? And then their answers were tape recorded or recorded and qualitatively analyzed. And in that qualitative analysis, these were the 5 themes that arose. So first, coping through one's spirituality. A patient saying, if it weren't for my faith, I don't know I would have kept my equilibrium through this process. Next, the role of spiritual practices. This patient talking about prayer. Another, the role of beliefs, forming or framing one's understanding of one's illness. This patient indicating, based on my religious beliefs, I think I was given a certain number of days on this earth from day one, and I don't think that changes with my diagnosis. A 4th theme being that of spiritual transformation, or a change in one's spirituality as a result of the illness experience. And then finally, the role of faith communities, patients frequently naming them as important to their illness experience. So you can see that spirituality is functioning in multiple dynamic ways. So that's an example of the importance of spirituality and illness. Now let's turn to an example of the relationship of patient spirituality to quality of life. That's addressed in this study, a multi-institutional cross-sectional study of over 1,600 cancer patients with spirituality measured with a validated scale, the FACIT-SP, and it's found to be an independent predictor of quality of life, and that's after controlling for other key predictors of quality of life, including physical well-being, emotional well-being, etc. Another way of looking at this is simply asking patients, well, what's most important to your quality of life in the setting of a serious illness? And that's what was done here in the study of over 1,800 seriously ill patients. They were given 44 potential attributes of quality of life near death. And ultimately in this study, the top 9 were ranked of those 44. And as you can see here, being free from pain and being at peace with God were number 1 and number 2 of those 44, with patients naming very much a spiritual construct, being at peace with God, as one of the most important factors in their quality of life near the end of life. And in fact, the authors of this paper note that these statistically tied for first with one another. So that tells us that spirituality plays an important role in quality of life. What about spirituality's role in medical decision-making? That's addressed in this paper of a survey-based study of 100 patients with advanced lung cancer, their family caregivers, and also of medical oncologists who care for cancer patients. They were asked to rank 7 factors important to the patient in making treatment decisions. And these are the 7 factors. All 3 groups, the patient, the family caregiver, and the physician, agreed that the ability of the treatment to cure the disease was the most important factor in the patient's medical decision-making. But next, for patients and for families, and last for physicians, which was patients' faith in God, illustrating how this is a salient factor in the minds of patients. The family member understands that that's indeed the case, but the physician does not recognize the important role that faith can have in a patient's medical decision-making. But does faith actually influence the types of medical decisions patients make at the end of life? This study would suggest it does. This is a prospective cohort study of advanced cancer patients examining the relationship between baseline religious spiritual coping. So a moment ago, I showed to you the qualitative analysis that showed that religious spiritual coping was one of the most important ways in which patients' spirituality is important in illness. So this study examined religious spiritual coping using a validated scale, Pargament's validated RCOPE scale, divided patients into high versus low based on a basic median split. The high is in blue, the low is in the yellowish orange, and then follow patients to the end of their life and examine the types of care that they received at the end of life. So here on the x-axis is being ventilated in the last week of life, being resuscitated in the last week of life, and ultimately dying in an ICU setting. And as you can see, patients exhibiting high religious coping at baseline were more likely to receive aggressive end-of-life interventions as compared to those with low religious or spiritual coping. This, of course, raises a question, well, why? Why is this the case that patients highly relying upon their religious or spiritual beliefs are receiving greater aggressive care at the end of life? A potential hypothesis is addressed in this study, examining the potential for religious beliefs in end-of-life care that are operative. This is a study of 275 advanced cancer patients in which they were asked these 7 potential beliefs in end-of-life care that could be operative. I'll just provide you a few examples. So the first one here, my belief in God relieves me of needing to think about future medical decisions, especially near the end of life. So the majority of patients had at least some endorsement of this item. Or here, this third item from the bottom, I believe that God could perform a miracle in curing me of cancer. Essentially 2/3 of patients endorsing this item. And in fact, 87% of patients endorsed at least one item, and 62% endorsed 3 or more items, just indicating that religious beliefs in end-of-life care are frequent, and these may be influencing how patients are making end-of-life decisions. So a fourth example is that of spiritual needs in serious illness. So this is the spiritual needs assessment for patients, or SNAP tool, a validated tool to assess spiritual needs. This study was of over 700 racially and ethnically diverse patients, cancer patients, seen at 4 New York City sites. In this study, interestingly, these were predominantly spiritual, not religious patients, which is a reflection of sort of the demographics of New York City. Within the United States, about just over 20% would consider themselves spiritual or not religious. So these are, predominated by those who are spiritual, not religious. And interestingly, however, spiritual needs are still very common among these patients, among these cancer patients. So, for example, over 15% desiring to find help with finding meaning, finding hope with certain spiritual practices, with help with their relationship with God, finding peace of mind, finding forgiveness, also common needs. And in fact, at least one spiritual need was reported by 79% of patients. So the vast majority of patients experiencing spiritual needs. And they go on to examine in univariate and multivariate models the relationship between spiritual needs and perceptions of quality of care and satisfaction with care. And what they find is that patients with high spiritual needs had lower perceptions of the quality of care in multivariate analysis and lower perceptions of satisfaction with care in multivariate analysis, suggesting that these spiritual needs really sort of influence the overall healthcare experience and should be addressed. So spiritual needs and serious illness has also been addressed by Arndt Bussing, who has developed this spiritual needs questionnaire, probably the most commonly used spiritual needs assessment tool. This particular study examined patients in Germany, those with chronic pain and or cancer, nearly 400 of them. And what they found, these are sort of the domains of their tool. It's quite an extensive tool with the domains of items that assess the need for peace, the need for generativity, or desiring to pass on and give to others, sort of an altruistic need, religious needs, so actually specific religious needs, whether it's connecting further with one's faith or certain religious practices, and then finally existential needs as addressing issues such as meaning and purpose. And you can see among this population, these needs are very common. And so just illustrating that in a variety of different population types, spiritual needs are very common in the setting of illness. How about how do spiritual needs relate to quality of life? This investigator, Marvin Delgado Guay, has created a validated spiritual pain single item screening question where the individual is asked, are you experiencing spiritual pain? And then spiritual pain is described as pain deep in your soul or your being that is not physical. And then it's assessed on a 1 to 10 scale, just like pain is assessed on a 1 to 10 scale. 100 consecutive patients seen at the MD Anderson Palliative Care Clinic in Texas in the United States underwent this single item screening item, and spiritual pain was reported in 44% of patients. So a large proportion of patients experiencing spiritual pain, and not surprisingly, it was associated with worse spiritual quality of life in adjusted models. So spiritual needs certainly have a suggestion of being influencing quality of life. I'd also like to address finally an example of how spiritual care, data suggesting that spiritual care influences outcome in illness. As part of this multi-site prospective study of advanced cancer patients examining psychosocial and spiritual factors and their relationship to end-of-life outcome, at baseline, spiritual care was assessed, including support of spiritual needs by the medical team, such as doctors, nurses, and chaplains, support of spiritual needs by spiritual communities, and receipt of pastoral care visits. Outcomes assessed were caregiver assessed quality of life in the last week of life, and medical care received in the last week of life. So first we'll look at the relationship between baseline spiritual care, whether or not patients reported spiritual care. I'm going to draw your attention to this bar graph all the way over to the right. Blue is when spiritual care was reported to be present, and over to the right here, this is any form of spiritual care reported by the patient as being present. And then orange is when it's absent. And then here on the y-axis, this is quality of life in the last week of life assessed by a caregiver present with the patient in the last week of life, with greater numbers meaning greater quality of life. And these are adjusted analyses, and you can see in these adjusted analyses, patients reporting at baseline that they had spiritual care integrated with their care had better quality of life in the last week of life as compared to those who reported no spiritual care. And this is after adjusting for a variety of factors, everything from baseline quality of life, as well as types of care received, et cetera. So suggesting that when patients have spiritual care integrated with their care, it is improving their overall quality of life at the end of life. What about the relationship of spiritual care and end-of-life medical outcomes? High spiritual support from the medical team, which was infrequent, only about a quarter of patients reported this. But when it was present, those patients transitioned to hospice more frequently, more quality of life focused care without aggressive interventions. And as you might imagine, because of that, they received less aggressive interventions and were less likely to die in an intensive care unit. And the impact of medical team spiritual support on end-of-life care was largely seen in those high religious coping patients. Remember, several slides ago, I showed you a slide that patients who highly rely upon their religious or spiritual beliefs to cope with illness tend to receive greater aggressive care at the end of life. Well, it's when these patients see a medical team who addresses spirituality, they no longer had that relationship. They tended to receive greater hospice care and less aggressive interventions at the end of life. Interestingly, high spiritual support from religious communities, which is more common, those patients transitioned to hospice less frequently, had greater aggressive interventions, and were more likely to die in an intensive care unit setting. And those findings were stronger among our high religious coping patients. These are only hypotheses, but one potential hypothesis is that it's the enforcement or reinforcement of religious beliefs in end-of-life care that I mentioned to you also a few slides ago, that perhaps these religious communities are upholding, that's sort of reinforcing an approach to care that's creating more decisions for aggressive interventions at the end of life. So I do want to spend a little bit of time examining sort of the systematic review of the literature on spirituality and health outcomes. In this topic. So we just were focusing on spiritual illness. So I'll just spend a few minutes looking at the systematic review on spirituality and health outcomes. So in healthy populations. So in this systematic review, the categories were all-cause mortality, overall physical health, health behaviors, mental health, and quality of life. We only chose those studies that were the lowest risk of bias, as illustrated here. These were studies that came from multiple continents and had very robust sample sizes, as you can see here, in the thousands, the medians in the thousands. And these were the 8 health outcomes that were found to be supported by strong evidence in our multidisciplinary Delphi panelist review. And I'll just illustrate that to you here. So it's generally spiritual community involvement. So being involved in communities that's influencing health outcomes. So first, spiritual community involvement is associated in very robust analyses with lower mortality. There's also this dose-response relationship. In other words, the more involved you are with religious communities, the greater the impact of that on lesser mortality. Community involvement is also associated with better quality of life and life satisfaction. It's associated with less use of various substances such as smoking, alcohol, and illicit drugs. It's associated with better mental health, with less suicide, with less depressive symptoms. And also among adolescents, it's associated with less risky behaviors such as sexually risky behaviors, as well as drug use, et cetera. So many robust associations with key health outcomes in these studies. These are some of the actual quantitative findings. So for example, in all-cause mortality, a meta-analysis including over 100,000 patients found a 27% reduction in all-cause mortality. Health behaviors and mechanisms. So for example, a nearly twofold higher odds of smoking cessation for those who attend religious services at least weekly. A 33% reduction in illicit drug use among adolescents. In disease-specific mortality, 27% reduction in cardiovascular disease mortality, a 21% reduction in cancer mortality among those highly involved in religious communities. And then finally, in mental health, about a 25% reduction in depression incidence for those highly involved in religious communities, and an 84% reduction in suicide among those highly involved in religious communities. So many sort of important quantitative findings, and again, very robust studies with because of the nature of the studies that these are done in, with the ability to look at these variables at multiple time points and to robustly control for confoundings, fairly compelling findings. So based on these studies, our multidisciplinary Delphi panel named the implications of this evidence for the practice of medicine and serious illness, and for the practice of public health. And I'll just illustrate these to you. So these are the top 3 that were named by that multidisciplinary panel that analyzed the evidence, that quantified what's the evidence that's supported by very strong, very robust evidence, and then ultimately named and ranked what are the most important implications of this evidence for the practice of medicine in serious illness and in health outcomes. So here are the implications of this evidence for serious illness. They are that we should be routinely incorporating spiritual care into the medical care of patients with serious illness. The second highest ranking was that spiritual care education should be given to the members of the interdisciplinary medical team caring for seriously ill patients. And then third, we should be including specialty practitioners of spiritual care, for example, chaplains, in the care of patients with serious illness. Next, in health outcomes, the implications are to incorporate patient-centered and evidence-based approaches regarding the beneficial associations of spiritual community participation to improve medical care in healthy populations and to improve population health. There also needs to be an increased awareness among public health professionals of the evidence regarding the protective health associations of spiritual community participation. And then finally, there needs to be recognition of spirituality as a social factor associated with health in research, in community assessments, and in program implementation. So I just wanted to again say thank you to all of you for listening today, for these considerations as we kind of considered the historical development of why we are where we are today in the relationship of spirituality to the practice of medicine, and used an empirical lens to begin to reflect on how spirituality has a role in the experience of illness, as well as an empirical lens regarding how spirituality influences population health, and considering how we can then take this evidence to then better care for patients who are suffering from illnesses, as well as caring for communities. So I will stop there and stop sharing my screen, and again say thank you to all of you for your attention today.